Good afternoon, everyone, and thanks for joining us today. This is Mohammed Nuruddin. I'm an assistant lecturer at Biology at Ancient University. And in the next few minutes, I will present my thesis about the role of focal HIFU ablation in the management of unilateral diagnosed low and intermediate risk prostate cancer. This thesis was submitted for fulfillment of Doctor of Medicine and Urology on the joint supervision between the Egyptian team, including Professor Professor of Urology at Ancient University, in conjunction with the United Kingdom team, including Professor Richard Henley, Professor of Urology at Manchester University and Consultant Urology Hampshire Hospital, with Professor Amr Amara, Assistant Professor of Urology at Ancient University, Consultant Urology Hampshire Hospital. The main aim of this study was to evaluate the focal HIFU prostate ablation in the management of unilateral diagnosed low and intermediate risk prostate cancer. And just before getting into the details of the study, I will review some of the knowledge from the up-to-date picture. We have to agree in the beginning on some concepts for the localized prostate cancer. We live now in the era where we have a robust evidence that not all the grades of the localized prostate cancer need treatment. We all know the PROTECT study, which didn't show any survival difference between the surveillance and the treatment groups of low and intermediate risk prostate cancer patients. In other terms, exposing this group of patients to the major side effects of the radical treatment will not add any survival benefit. However, there was less metastasis in the treatment grouping provided to the surveillance group. In the PROTECT study, there was no overall survival difference between the observation grouping compared to the prospective group. But regardless of all the pitfalls of this study, we need to focus on the fact that the high-risk group patients showed more survival benefit with the prospective. So by active surveillance, we can defer the radical treatment for some time, but the progression seems to happen in some cases. So why is that? Klotz, who published in 2015 the largest and the longest active surveillance series for low and intermediate risk disease, he showed that after 15 years of follow-up, almost half of these patients were referred for radical treatment. Also, Hafner reported in 2013 a genetic analysis from a single patient with metastatic prostate cancer after radical prostatectomy that showed, interestingly, the genetic pattern from different metastasis site is very similar to a small Gleason 3 focus, not a Gleason 4 tumor. So he concluded from that the low-grade cancer could metastasize and low. Then later, in animal genetic studies, in which this fact was tested, it showed that the genetic pattern of a high-grade disease could influence the behavior of other low-grade. Actually, quite similar to the influence of growing up naive small kids in a bad-aggressive family. When they grow up, they turn out to be a big family. So, are we saying that the active surveillance is not a good option? The answer is definitely no. It is a good option, but what we missed that good amount of the data that we rely on it now is based on the old way diagnosed prostate cancer, such as the non-targeted prostate biopsy, which could easily miss other cancer, right? And that will influence the outcome of the patient treatment. And take this case as a real example. This man was started in active surveillance as he was diagnosed on prostate cancer Gleason 6 using a trust biopsy in 2016. And when he progressed, he had a radical prostatectomy 2 years later, and the prostatectomy specimen showed that he had an anterior lesion which was Gleason 4+3, which on re-reporting his MRI was reported as a light history. And this was impossible for any trust biopsy to take it out, and that's why he failed his active surveillance. So this showed the utmost importance of MRI targeted biopsy in the current era. The whole point in the diagnosis of localized prostate cancer now is to know whether it is a non-significant cancer, so we can offer surveillance, or if a significant ones, the patient would definitely need to face the radical treatment option with its big impacts. And this is what is stated in the current guidelines and approval by the recent evidence. The non-significant areas would be safely surveilled, but the significant cancer, due to its risk to progress and metastasize, they need to be aggressively treated by the radical treatment option, which gives us a very high curative outcomes, but with much functional side effects. And this was the pushing point for the idea of the focal therapy to develop, that we need something that can control the cancer efficiently, which is a cancer grade that will not be for active surveillance, but with less side effects. The idea was originally imported from the breast cancer management. In 2002, Bernoussi published the outcome of the randomized study between the radical mastectomy and the breast conserving surgery, which showed really reliable cancer control results with less side function depending out. To take the idea forward, in 2011, Hashim Ahmed published the first study for the focal therapy of total of 20 men who underwent HIFU hemiablation patient. The mean age for this group of patients were 60, and the pre-treatment PSA was 7.3. 90% of them were bad-free after 1 year, and the PSA decreased by 80% to 1.5 at 12 months. So the focal therapy was not just an alternative to active surveillance, but was an actual competitor to the radical treatment option with this side. And from this point, the focal therapy started to have attention of many surgeons and patients. But the question was always, can we treat any stage of the cancer or grade with the focal therapy? And the index lesion concept held it in some way answered the question. The evidence showed that some lesion, according to its volume, lesion grades, and staging, will show more prognostic features over other lesions. And the study showed that 88% of the multi-cancer diseases will have a dominant, which would be more prognostically important. So on the basis of this concept, the focal therapy shifted from a whole gland treatment to a focal treatment. And we know from the prostatectomy data now that the secondary cancer didn't influence the preoperative parameters such as the PSA or the biopsy results. What have made the difference in these areas was the percentage of the Gleason 4 and the Gleason 5 of the diagnostic biopsy. So again, the whole trick is the diagnostic modality, whether it is competent enough to show the actual significant lesion, which will definitely be treated. But the index lesion, which realized later that it's a double-edged weapon, as by believing in it, the focal ablation strategy showed high recurrence rate. And the reason behind that was shown in the data from Leonard Marks in the University of California, Los Angeles. His team used the data of 114 men who underwent MRI before their prostatectomy, and the team did a sort of patient-specific molding processing of the prostatectomy specimen. These molding contours were aligned with the MRI images to show the actual difference between the MRI and the histology activity. This process showed that the MRI underestimated the tumor length by an average of 11 millimeter and underestimated the volume by approximately 3-fold. So this shifted the whole concept of focal therapy again from just a focal ablation to hemi-ablation or quadrilateral ablation or at least a zoom ablation. So currently there are multiple factors that should guide us in selecting the patient for the focal therapy. The tumor grade, for example, should be not more than Gleason 7 to have focal therapy, although occasionally now we can treat Gleason 8 if it's a small and localized area. The gland size itself is not an actual obstacle in the case of the focal therapy, but the size may affect the HIFU as an option for the focal length issues, and I'll speak about that in a minute. Patient for focal therapy should have a form of or MRI targeted biopsy, or at least a template mapping biopsy before the treatment to be able to assess the nature of the other areas in the if they are accessible. And we currently accept to leave an area of insignificant disease untreated if it is less than 5 millimeter and Gleason 3+. The panel didn't recommend one for focal therapy modality over another. However, I think most of the focal therapies were influenced by Professor Barrett and his colleagues' work in France 2016 about the selection of the best modality of focal therapy according to the location of the lesion, which is called a la carte approach. They suggested that the posterior tumors are very intimate to the rectum, so the HIFU will be the best option for this patient, as the ultrasound waves could travel easily from the rectum to the prostate. For the anterior lesion, the ultrasound wave may not reach through the gland easily, and the transcranial needle of the cryotherapy will be visible accessibility. When it comes to the apex, the thermal and the ice energy will cause inevitable damage to the urinary sphincter. So other forms like the radiofrequency ablation or the electroablation nowadays would be more. So speaking about the HIFU itself, we need to understand the physics in the beginning of the HIFU. The main difference between the HIFU and the ultrasound image, the normal ultrasound image, is that the acoustic ultrasound waves in the HIFU are intensified and focused to a single point. It's quite similar to collecting the sun rays by a lens onto a paper and burning it. So by focusing the waves in this way, this converts the energy into heat, and the heat will cause coagulative necrosis. The tissue ablation by this energy takes place in 2 ways, either thermal and mechanical. The thermal effects start by elevation of the tissue temperature, lead to melting of the lipid and protein denaturation, which result in a gas and bubble formation and cavitation. And as we see in the video here, this white infield change, which is called the popcorn effect, is due to the gas and the bubble formation. The mechanical effects having to do with focusing of the acoustic waves in a certain point, which create pressure by the gas formation and cause a tissue to move. There are two main HIFU devices for the prostate ablation. The sonoplate is remarked by having a single transducer for both the imaging and the treatment. And it's 4 megahertz transducer with a range of focal lengths between 25 and 45 millimeters, which give a treatment diameter up to 40 millimeters in the sagittal plane. The Ablasan has 2 transducers, the 7.5 megahertz for imaging and the 3 megahertz for the treatment. And both are integrated in a single probe and give a range of treatment up to 45 millimeters. The HIFU procedure is usually under general anesthetic. The sonic care device is usually operated on lysotomy position. Much lubrication is required when the probe is applied constrictively and image acquisition then starts. Planning is the next step, which starts by measuring the gland size. And then we select how many ablation zones needed. Then a slight adjustment of the prostate areas, just to make sure that we are focusing in the area that we are treating. Then the planning happens in the next step, then that. Yes, it's mainly done by most of the patients go home later on the day or stay over the night. Your critical cluster is usually left in average week time. For the first year, patient will be reviewed every 3 months with a PSA test. At a 9 and 12 months or 12 months, MRI will be arranged to check about any recurrence or untreated areas. Sometimes we may need to get an early MRI if the PSA is not reassuring, and we usually arrange for a prostate biopsy in case of suspected areas of lesion. If there is any treating, if there is any recurrence or untreated area, treatment is usually arranged according to the grading. So as we see, it looks as a really straightforward, less invasive maneuver, but how effective is it? In a recent multi-centric study in the UK, 1,032 patients underwent HIFU for localized prostate cancer from 2005 to 2017. And it was shown that the freedom from biopsy failure after treatment was 94, 84, 64% at 12, 24, and 60 months respectively. In a very recent one, actually, came like a few weeks ago, but wasn't included in the thesis, but our data from Basing stock was included in it. 1 in each 10 patients in 1,300 patients required whole gland treatment at one point of their long follow-up. A prospective multi-centric single-arm study with unilateral and low and intermediate risk prostate cancer patients treated from April 2013 to March 2016 in Germany. The results showed that the biochemical disease-free survival rate at 5 and 10 years were 81 and 61% respectively. Was this effective oncological outcome? The collective data showed that the functional side effects are low. Collective data showed that the risk of recurrence function is around 5% and the risk of incontinence is around 8%. So the common question which would usually rise, did we lose anything by doing focal therapy for patients? And under that, there is no currently a protocol or guidance on the treatment for the failure phase after the focal therapy. However, different scenarios could be offered according to the state of the recurrence. Active surveillance is an option if it is a low grade and a small volume recurrence. Redo focal therapy is also a feasible option, but it depends mainly on the grade and the size of the lesion. All patients can be referred for the radical treatment option. It's still a really feasible salvage option. So moving to our study, the sample was designed to be on 50 patients of a low and intermediate risk localized prostate cancer, and to be treated by HIFU in Basingstoke Hospital for 2 years, and to collect the data prospectively after that about the PSA result, the MRI result, the follow-up by recurrence. Does everyone mute themselves? The study primary outcome was to report the failure-free survival rate in the low and intermediate risk group, which is defined as the absence of transition to the whole gland, radical, systematic therapy, metastasis, or cancer-related risk during follow-up. Secondary outcome, including reviewing the different treatment results in the low and intermediate risk group regarding the PSA relapse, recurrence rate, metastasis rate, incontinence, change in the IPSS, changing in the erectile dysfunction score, and the use of phospholipid. Our results were really interesting for the short term. From the demographic results, our patients' average pre-treatment PSA was 6.4, 64% was either 2, 26% of them was either 3, and only 10% was either 1. Most of them had a hemiablation. This proportion had focal and primary ablation. 9% of our data had an untreated insignificant lesion on the contralateral side. And our follow-up duration was up to 21 months. It was average of 16 months. We have 3 patients in the intermediate risk who needed radical prostatectomy in the follow-up duration, and they were referred to a tertiary center for that. 2 of them were from the ISO 3 group and 1 from the ISO 2. 1 patient in the low risk disease needed radiotherapy due to progression of his disease to Gleason 3+4. And from the metastasis point of view, only 1 patient in the cohort full of metastasis, but I think his diagnostic biopsy is not that accurate. So our total failure-free survival rate was 88%. It was 93 for the ISO 2, and it was 76.9 for ISO 3. The median BSA decreased by about 65% of its baseline before the treatment, reaching 2.2 in the first 3 months. And the median BSA in Nazir was 5.1. This was reached in 7 months, 0.6. BSA relapse was observed in 24% of the patients, and only 1 of the patients was in the low risk group, and the rest was in the intermediate risk group. There was no difference between the ISO 2 and ISO 3. For the MRI results, 72% of our patients, their MRI didn't show any concerns of recurrence. 8 patients showed outfield suspected areas, and 5 patients showed resistant infield suspected areas. For the post-treatment biopsy, it confirmed a clinically significant disease in 2 patients in the treatment area, and 1 patient with Gleason 3+3. The rest, 18 patients who had biopsy, showed benign histology. All the patients were kept less than 24 hours in the hospital. They were discharged from the hospital with a racial catheter for an average of 5 days. 86% passed their trial without the catheter in the first time. 5 patients got retention in the first time, and the catheter was inserted again. 4 of them needed intermittent self-catheterization, and 1 only managed to get rid of the catheter. During the 2 years follow-up, 1 patient needed bladder neck resection, and another 1 needed an optical ureterotomy. However, all the patients were bad-free. The median IPSS for the treatment was 8, and it's improved to 4 during the first year and dropped to 0 in the second year. And 22% of our patients complained of erectile dysfunction in the follow-up duration, which is 11 patients. 9 of them got significant improvement on the phosphodiesterase inhibitors, either sildenafil or tadalafil, and 1 patient needed a vacuum pump, and the other needed Muse. So as a discussion, where is this study in the field of the focal therapy? I would say that this study was one of the multi-studies showing the abilities of the focal therapy to control the prostate cancer in comparable way to the radical treatment. Our follow-up was a short follow-up. It was only for about 22 months. Other studies like Viva reached 120 months. Our patient reached a PSA Nadir of 1.9, which is quite close to the other big focal therapy studies, such as Ahmed in 2011. His PSA was 1.5, and Viva was 1.52. The failure-free survival rate was the best in Ahmed because it was a very short and small amount of patients, it was 100%. But for example, Figon, which is one of the longest, was 90%, and Van Belton also reached 93%. Our failure rate is 13%, which is really comparable to the failure-free survival rate in the radical prostatectomy and radiotherapy studies such as ISO in 2000. So our function results also is very comparable to the collective data. There is usually a risk of, after the hypothetical incontinence, which as I said is about 8%. It's usually around 12%. Urine retention is 5%. Restricting fistula is 1%. This is what is in the collective data. In our study, only 4% of the patients get a rectal stricture. None of them developed urethrorectal fistula, and 8% needed self-catheterization after the fall. Erectile dysfunction, as we said, the average stricture for the prostatectomy say is from 5 to 40%, but in our data it was 22, and a very good number of them managed to get a very good improvement on the however, I would say our study has definitely several limitations, which is worth noting. Over the time allowed in the Thesis study in our affiliation and the need for a prospective study, the time to recruit and follow up patients for this study was limited to 2 years only, which recognized the study as a short-term outcome study. The study was designed 6 years ago to compare the outcomes from low and intermediate risk prostate cancer group. However, the actual study time was in 2018 and 2019, when the low-risk group patients were offered just active surveillance as a standard of care in the UK. So we didn't manage to recruit a lot of patients for low-grade cancer. We were influenced also by the other ongoing trials protocol happening at the same time to our study, which led to having some pre- and post-operative treatment biopsy as TRUS biopsy rather than the transcranial biopsy. The impact of this study, I hope that this study and any future work as a joint collaboration between Ain Shams University and Hampshire Hospital will give a great impact on the two centers. Looking for this study as an example, to our knowledge, this is the first study from an Egyptian center in the field of the primary HIFU therapy for the localized prostate cancer. Exploring the UK experience in the field of the prostate cancer diagnostic and focal therapy will be an inspiring push to the team to transfer this experience to Ain Shams University and Egypt in general. The research outcome in this field is illustrated in the fair amount of the research work and publications that were released during the duration of this study. We helped in publishing the Thesis 9 years focal therapy outcome in the Golden Journal of Astrology. And part of these results of this thesis were presented in the Focal Therapy Society in Washington. And there were other publications from the literature about the imaging modalities and the prostate cancer diagnosis. To sum up at the end, it's obvious. Are we given we lost the Zoom? I will just join again the Zoom.
قال لك extended release. في بس انت مشترك فيه.
Just try to unmute myself because I think I still have some.
Hello, could you hear us?
Hello?
Assam, we can hear you, Assam.
Fair enough.
Yeah, I can hear you. It's all
Thanks.
fine.
Okay. But can you see our screen or not? Yeah, okay, thank you.
Yes, yes.
Yeah.
It's obvious through these results that the current available medium and long-term literature that the HIFU treatment for localized prostate cancer has a high control rate in the intermediate risk group, especially the ISO2. On the other perspective, the function side effects are really limited in comparison to the whole gland treatment. However, up to the current time, the published literature lacks randomized control trial testing the long-term outcomes of the focal therapy in general in comparison to the whole gland treatment. At the end, just to give everyone his due, I'm really grateful to my big family in Ain Shams University, especially Professor Tariq Zahir for his massive support during this thesis and his continuous help, and also Professor Sharif Muad for his support since I was his resident in Ain Shams Specialized Hospital and still ongoing support. So thanks, my dear professor, for being in my career. Thanks for Professor Henley for his great support throughout my whole journey, for teaching me Zoom, focal therapy, green light, laser. It was a great honor to work beside him for the last few years. And for Professor Imara, I'm not just considering him as my supervisor or my consultant. He was actually my elder brother who supported me and helped me even before my first steps in the UK. Him and his nice family, I hope Allah give them the best wishes. I'm also very grateful for my discussion committee, Professor Arman Ware. It's a great honor to myself to have him in my discussion board. Thanks for coming. And also great pleasure to have Professor Tariq Zahir. Thank you for being there. I would just like to thank my family that I have caused them a lot of hassle to get this work done throughout my career, and I have moved them a lot. So may Allah bless them all. I would say I learned a lot of things during this journey, from seeing different things in different places. I've seen and learned.
I already on.
I think someone need to mute.
How's that? Okay. ماشي.